So I think we're going to um, start with the next presentation. So, friends, I'd like you to help me welcome Dr. Candice Monson to the Family Summit. Dr. Monson is a leader in using couple-based interventions to prevent and treat PTSD and associated problems. We're very happy to have her join us this afternoon. Welcome, Dr. Monson. Over to you.
Thank you so much, Hep. I really appreciate it. And I am honored to be able to present in today's presentation, specifically about couple and family therapy for PTSD. This is a topic that is near and dear to me, and I've spent the last nearly 25 years actually focused on thinking about PTSD existing beyond the individual and having repercussions in the lives of those who live in relation to someone with the disorder. So this presentation is really designed to give people a way to think about how we can do couple and family therapy for those with PTSD and what the future might hold in the way of doing couple and family therapy for PTSD. One thing I should say at the outset is that it takes a village to do treatment research, and this is very applied research. And we've had a range of different funding agencies and a very large team of people who have actually made this work possible. So I want to just at the outset make sure and give a nod to those various agencies who have been so generous in their support. All right, so where are we going? So today I want to talk about a way to conceptualize or formulate how we include partners and family members in PTSD treatment, and then talk a little bit about the evidence for doing couple family treatment for PTSD, some interesting pattern of findings, and then also like what's the promising path ahead in terms of things that are coming down the pipe. So, drum roll, I wanted to have the top 5 reasons to think about couple family therapy for PTSD, but there were 6. So, we're going to go with 6. So, number 6 is that intimate relationships in and of themselves are associated with the likelihood of engaging in PTSD treatment. So, people who are in supportive, intimate relationships are actually more likely to have a loved one who will engage in PTSD treatment. And at the same time, number 5 is we know that PTSD is one of the mental health conditions most associated with relationship problems. So the only condition that actually outpaces relationship distress is mania. So PTSD is definitely one of the most common to be affected by and affect intimate relationships. The other thing for us to think about is while we have some excellent evidence-based therapies, we know from all kinds of meta-analyses that there are people who don't respond or only partially respond to those treatments. And I would say a lot of the treatment outcome research, including my own, so I'm guilty of this as well, has really looked at symptomatology. So, PTSD symptoms, but also anxiety, depression, guilt, anger, etc., and a bit less of a focus on psychosocial functioning or the interpersonal functioning of the people who receive these treatments. And one thing that you might be interested in knowing, but probably not surprised in knowing, is that those existing therapies don't actually improve intimate relationship functioning. So for a long time, there was like lore, like if you just treat the post-traumatic stress symptoms, it will have trickle-down effects. And like trickle-down economics, there probably is not a lot of evidence for this. And in fact, I ran one study of cognitive processing therapy with veterans showing that those people who got cognitive processing therapy, actually their extended family relationships worsened. And the idea there is, you might improve the individual, but they're going back into a system that has a long history of a way of interacting. And just because you may treat an individual in the system, it doesn't mean that the system is healthier, and it actually may cause turbulence in that system. We also know that a negative family environment is associated with worse outcomes in the individual treatment. So if you're existing in an ambiently stressful relationship, that's not going to make it as easy to profit from individual treatment. And I think one of the most important reasons to think about couple family therapy for PTSD and other mental health conditions is one of efficiency. So being, ever pragmatic, how do we get multiple outcomes from a single therapy? So by doing these therapies, how can we not only improve PTSD and comorbid, all those co-travelers that go along with the symptoms, but also improve the relationship? And we know that the close others who are living in tandem with those with post-traumatic problems, they have their own problems, and you're getting well acquainted with those, perhaps experiencing them yourself. That there's a wear and tear that goes along with being in relationship with someone who has post-traumatic problems. We also know that people who have post-traumatic problems are also more likely to be partnered with people who have mental health problems. So the more that we can improve the individuals in the system and the system, then we can get multiple outcomes, and also probably improve the likelihood that those outcomes are maintained over time. So if you don't hear anything else in this presentation, I do think this is one of the most important slides, just in terms of thinking about what is the goal when you're doing a couple family therapy. And you'll see on this slide, I've labeled it a conjoint treatment, which is just a fancy way of saying, like, including at least one other person in the treatment. And again, this may or may not be a family member. So either a created family member or a family of origin member. It could be someone who's considered just a concerned significant other in the treatment. And you'll notice that in this matrix, there is the target of improving individual symptoms, and then the target of improving relationships. So depending on what your focus is, you may be interested in improving post-traumatic stress symptoms, or you might be interested in improving the relationship between the people that are there in the room with you. And what that means is that it kind of calls for different interventions. So we are, I think, most used to this cell in the matrix. So when we add on or we refer to a couple family therapy, we tend to think about, like, our major target is to improve their relationship. But it may or may not improve the individual symptoms. And that's what we would call generic or general family therapy. That's in contrast to this quadrant here, where I'm really focused on improving post-traumatic stress symptoms, but I'm less invested in improving the relationship. So we would call these partner-assisted interventions. So just a fancy term for how do we include the loved one in the treatment in order to either A, kind of get out of the way of the treatment, or to facilitate the treatment. So you might, for example, have a person with PTSD symptoms who's doing an exposure-based treatment, which is essentially, face what you fear, either the memory that's in your head or reminders in your environment, and keep doing that and doing it and doing it until you're bored. You might include a loved one as like a surrogate coach or surrogate therapist or coach to assist in that intervention. but you're not necessarily attending to the relationship between those two people. And I raise this because I think one of the concerns about partner assisted interventions is that it really depends on the quality of the relationship between those two people about whether or not you can actually pull this off. Because if I'm in a relationship with someone that's contentious or toxic, then having them be my coach or surrogate therapist is probably not going to go that well. So it's, I think, an important factor for therapists and loved ones to really think about in terms of, is this going to work for a loved one to serve in this role? There are some interventions here in this quadrant that aren't really aimed at improving individual symptoms or the relationship, but may have important service delivery functions. So when I say service delivery functions, I mean, for example, psychoeducation. Lots and lots of programs provide psychoeducation about depression, PTSD, anxiety, panic. There is absolutely no evidence that psychoeducation alone improves post-traumatic stress symptoms. It's probably a necessary but insufficient component of treatment. So it's probably important in terms of the service delivery, but not sufficient in actually improving symptoms. There's also a set of interventions that have been developed called family facilitated engagement interventions, which are really about, how do you get someone to treatment? So, I've had a career of like creating treatments, trying to get clinicians to offer those treatments. But if we don't get people to them, it doesn't really matter. So, and a lot of people, as you know, are not that interested in getting treatment, or it may take a while for them to get treatment. And so these are interventions that are designed to actually help the family to know about the kinds of things to say, things that support them in encouraging their loved one to actually access treatment. And then finally, there is this quadrant of interventions that are called disorder specific family therapies. And you'll notice they are actually designed to improve the individual symptoms, but also target the relationship. So I think about them as like a mashup. So we're taking what we know about how to improve depression or anxiety or PTSD symptoms, and we're mashing them up with what we know works in terms of improving relationships. So in this way, it's like getting family therapy for a specific condition. And there's a long history of doing couple family therapy for all kinds of conditions. So depression, substance use, there's a long history of substance use, family-focused therapy for substance use. PTSD was a little bit later to the game, and partly because PTSD is a newer diagnosis than these other diagnoses. But I think also because of some ambivalence about, how do you actually include family members in PTSD treatment, and be respectful of some of the individual concerns in terms of the trauma memories and experiences, and like how exactly are we going to do that in a way that's not unduly distressing for loved ones. Okay. I just wanted to point out that a lot of what I'm going to show you in terms of the evidence for these couple family therapies has been published in this really excellent handbook. If you want kind of a one-stop shop for PTSD, the science and the practice, this is an excellent textbook that's been published. And there's a chapter in it that my colleagues and I did that is focused on couple and family treatments. So this is in one place a review of the treatments and that have been shown to have some level of evidence to support that they work. So maybe just starting over here in the quadrant that's focused on getting people into treatment and providing psychoeducation, Michelle Sherman and colleagues have a curriculum that's called the SAFE program, so support and family education. It's for all kinds of mental health conditions, but includes a fair amount of focus on PTSD because they developed this program within the United States VA. There's also there are 4 different interventions or treatments that have been shown to work to improve relationships in those who have PTSD, but there's really no evidence that those treatments improve the individual symptoms of PTSD. So a classic, well-researched intervention is behavioral couple therapy. This is really focused on improving communication skills mostly. Behavioral family therapy, which is just an application of behavioral interventions in the family context. There's something called the Coach program, which is an Israeli program that is offered to veterans and their spouses that has evidence. And then the REACH program, which is a program that expands the SAFE program and has been tested within the US VA, showing improvements in the relationship, but not necessarily the symptoms of PTSD. There's one program that has a bit of evidence that's an Australian program called the Lifestyle Management Course that was tested by Grant DeVilly. And this is a program where partners were included as part of an intensive program for the veterans that were focused on kind of lifestyle and relationships. Again, showing improvements in the individual symptoms of PTSD, but not necessarily in the relationship. And then there are 4 different treatments that have been tested and shown to actually improve both areas. So the first of those is cognitive behavioral conjoint therapy for PTSD, which is a treatment that Dr. Stephanie Fredman and I created and have tested. Fred Sauter and colleagues have developed and tested strategic approach therapy, which is a very behavioral type of treatment that's all about getting couples to approach those things that have been avoided, that are trauma focused and also relationship focused. Sue Johnson has developed a version of emotionally focused therapy for couples where there is a focus on trauma, and emotion focused therapy was originally developed here in Canada, and then Sue applied it to trauma. And then my colleague Jeremy Shum, who actually developed a couple therapy for both addiction and PTSD. So taking what we know works with substance use problems and PTSD and combining it with what we know works for couple therapy. Okay, so this next slide is kind of interesting in that it is designed to kind of help you understand and be a good consumer of the findings in this area. So some of the things that I think are important to think about with couple family therapy is, are you recruiting couples where they have relationship problems and they may or may not have PTSD, but there's a history of trauma? So keep in mind, a history of trauma does not necessarily mean that you have PTSD, but it means you have a history of trauma. Or are you recruiting couples where there's a person in the couple who has PTSD as a disorder, and the relationship may or may not be distressed, right? So I'm raising this because it really depends, like, what are you going out and trying to find? Are you recruiting on the relationship and distress in the relationship? Or are you recruiting on the disorder? Because the pattern of finding looks, you'll see here in a second, looks different depending on what animal essentially you've gone out and are planning to treat. The other thing that's super interesting is it really depends on which partner satisfaction you're looking at. And we're going to talk about, I'll give you a little tapa related to that, which is it really depends on the gender of the partner. So we'll come back to that. I'm going to talk a little bit more about this word here, equipoise. If you break it down, it means equally poised or equally ready for different therapies. And when you compare different therapies, how important this notion is. I'll come back to that with an illustration to help you to kind of think about patient preference and are people getting what they want? And then there's been some really interesting things that have emerged in the last couple of years about dosing. So how do we change, instead of kind of more traditional once a week therapy, how do we potentially do weekend retreats and treat people faster and more intensely in order to get people better faster? And then finally, there's an interesting set of research that's all about service delivery and access. So video into the home before the pandemic, this was like a novel thing. Obviously, there's lots of therapy that's going into the home. But how do you actually deliver therapy into the home via video? The idea of using online delivery, so using the web and web stream videos, for example, to actually deliver treatment. As I mentioned before, weekend retreats, and then primary care integration. So how do we do kind of shorter and more accessible interventions that are integrated into primary care? Okay, so this is a figure to illustrate this piece that I had raised before about, like, what are you recruiting for? So a lot of the studies and treatments have gone out and recruited for the disorder, including the treatment that I created. So cognitive behavioral conjoint therapy for PTSD. You really are thinking about, we're going to treat this disorder, and it happens to be in a couple family context or frame. Same thing for strategic approach therapy and for traditional behavioral couple or behavioral family therapy. So in all those studies, you're actually recruiting for the disorder. In the case of emotionally focused couple therapy, they have been recruiting on having a history of trauma and recruiting couples where there is relationship distress. So if you were otherwise happy and satisfied, you wouldn't necessarily be eligible to participate in the studies that have been done on emotionally focused couple therapy. So the take-home message is that it really depends what you're seeking to treat and what you will get as findings. So in the case of recruiting for PTSD, if that's what you're going out and you have created a treatment to treat, then the findings are quite clear that you improve PTSD. Whereas emotion-focused couple therapy, the findings are quite mixed about whether or not it improves PTSD, but clearer that it improves relationship distress, which again, I think it's no surprise. It just really depends on what it is in our world, which are inclusion criteria, like what is it that you are aiming to improve, and that is going to depend on who you're going out to recruit to be in your study. Okay, So I already alluded to this idea that in a couple, when you're measuring people's satisfaction, you have two people's satisfaction, right? In a couple. And depending on whose satisfaction you're measuring, there is a different pattern of results. So I wanted to just show you this. So again, let me just orient you. Here across the top is it the PTSD positive partner, or is it the person who does not meet criteria for PTSD but is participating in the study? And so one thing you probably will pretty quickly notice is that, at least in the case of our treatment, the partners seem to report they're significantly more likely to report improvements in the relationship. And this is, I should be clear, this is the number of studies that have been done, and then the number of studies that have shown improvements. So to make that super concrete, in 2 of the 8 studies for our treatment, the PTSD positive partner is reporting improvements in relationships, whereas the partners, 5 of the 8 studies show that the partners are reporting improvements. Similar pattern for strategic approach therapy, where a bit more evidence that the PTSD positive partner is reporting improvements, but not the partner. And about half of the studies, when it comes to emotion-focused couple therapy, and when we look at just general couple family therapy, there is about 2/3 of the studies show that there are improvements in relationship outcomes. Now, one point that I want to make with this is that in our studies, most of the partners are women, whereas the person with PTSD is, and these are mostly heterosexual relationships. Most of the persons with PTSD are men, because a lot of our studies have been done with veteran samples, first responders, and active duty service members. And if you look, you may be interested to know, if you look at the couple family therapy literature, women tend to be more responsive to our couple family therapies. They tend to also come in with more distress than male partners. So it's kind of interesting to see where our improvements may be occurring with regard to at least heterosexual couples. We've started to expand more and more and actively trying to include more diverse couples, not just with regard to gender and sexual orientation, but also with regard to the range of individual variation. All right, so one thing that people often ask me is, okay, well, how do couple family therapies perform compared with individual therapy? So it's like this idea of like a horse race, like who wins if you do a couple family therapy for PTSD versus an individual therapy for PTSD. And in fact, we hazarded to do this study, and we specifically tested our cognitive behavioral conjoint therapy for PTSD versus prolonged exposure in US active duty service members and veterans. And a couple of things that came out of that study that honestly I still have some bruises and scars from is that it was incredibly hard to recruit for the study, because people told us, we're coming because we want the couple therapy. We don't want to be randomized to get the individual therapy. And then when they were randomized, I want to show you this, which is of the people who were distressed in their relationship, distressed in their relationship at the beginning of treatment, and who got assigned to prolonged exposure, only one of those 6 people actually completed the treatment. And that's in contrast to over here in the couple therapy condition. 8 of them started distressed, 7 of the 8 completed. And I raise this because I think we have to really, really respect what it is that people want and the notion of people getting the treatment that they want. So this goes back to this idea of equipoise. So in studies where you're randomizing people, both of the choices have to be equally desirable, and you have to be kind of equally poised to want to do them. And what became very clear to us is that for people who are coming to our study offering a couple therapy, they were either reluctant to proceed, knowing that they could be randomized to the individual therapy, or if they were willing to proceed, but then they were in a distressed relationship and got the individual therapy, they dropped out. So I think as we are becoming, I mean, it's kind of a no duh, like, give people what they want and they do better. But it's a very well documented study to this idea that patient preference really matters, and that we need a range of treatments that people can profit from, and that we aim to really meet them where they're at and to receive what it is they want in order to get better. Okay, so just to talk a little bit about some of the newest research that's coming out, looking at abbreviated and mass delivery of treatment. So my colleague, Stephanie Fredman, who I mentioned, wrote the treatment manual, the CBCT for PTSD treatment manual. She took that treatment, abbreviated it, so made it a shorter version, and set up a curriculum that was essentially delivered on a Friday night, Saturday, and Sunday morning as a retreat. And this initial study was actually just a proof of concept. Like, does this actually work potentially, and is it safe and desirable and feasible? And so there were 24 couples who participated in the States. They delivered the treatment as a workshop during the weekend. As I mentioned, all the couples completed the treatment. They all went to a retreat setting. They all completed. And there were significant improvements in the service member veterans' PTSD and comorbid symptoms, but also the partner's psychological distress and their relationship functioning. So this is just a pictorial description of that. So here is the clinician's rating of PTSD, patient's rating of PTSD, partner's rating of PTSD, depression, anxiety, and anger. This is all patient outcomes. What I wanted to show you in this graph is, first of all, these are what are called effect sizes, which is just kind of like how a standard deviation's worth of change. So kind of how big is the change? So you want bigger is better. And a 0.8 effect size is considered a large effect. So that gives you kind of some benchmark for understanding these results. But I think what's super interesting about our findings here is that the improvements in these various problems actually increased with time. So this is 1 month after the retreat. And then these gray bars are actually 3 months after the retreat. So it wasn't just like an immediate effect of being away for a weekend with your partner. Like, who can't stand a weekend away with your partner? But actually, there's something that's happening after those retreats where the gains may be growing. And so that's super interesting. we're now doing a follow-up, a really large funded study by the US government to compare this intervention, this treatment, to PrEP, which is a treatment that's also a weekend treatment for couples to improve their relationships. It started out and was called PrEP because it was premarital prevention of distress, and it's since been applied to couples where there is distress. So some really promising results to show that in a short period of time with an intense focus, that people can actually get better. Now, likewise, in this study, you see that partners' own psychological distress and relationship satisfaction improves. So this is their anxiety and depression. And just like in that prior slide, it looks like the partners' improvements are growing with time, and that at least for the partners, there are significant improvements in relationship satisfaction, and that it's growing. You might find it interesting that anger was a smaller effect for partners, and relationship satisfaction kind of barely improved in patients. But remember, we're not recruiting for people who are distressed. We're recruiting for people who have the disorder, and they may or may not have relationship dissatisfaction. So it's harder to improve someone who's already satisfied than it is to improve someone who is having dissatisfaction in their relationship. Okay, let's talk a little bit about in-home delivery. So my colleague Leslie Moreland, who's at the San Diego VA, picked up our couple therapy for PTSD, and actually also abbreviated it, made it an 8-session, or just the first 2 phases of the treatment, so 8 sessions. And in this trial, this is the largest couple therapy trial ever conducted. And in this trial, we compared 3 different versions of intervention. So the first was to deliver the treatment in an office. So the couples came in, got the abbreviated CBCT in an office. Then there was also a home-based version where it was video into the home. And then there was a psychoeducation version of treatment, which was just purely all about like the symptoms of PTSD and other conditions that can come from trauma. And these are those effect sizes that we talked about before. So bigger is better, and what you'll see, kind of one of the most important take-home messages, is that there was no difference between office-based and home-based treatment delivery. So it doesn't seem like there's something unique to having people in the office, which again, at the time this study started, everyone was like, oh my God, can you do couple therapy on video? No one had published a video couple therapy study. Of course, the pandemic obviously pragmatically changed things, but this was an important study to even show like it doesn't degrade it by delivering it over video. And these treatments are better than just getting straight up psychoeducation that's delivered to the couple. Interestingly, all 3 conditions improved satisfaction. And this is specifically the veteran. And just to note, this is the couple satisfaction index. Higher score means more satisfaction. So there are improvements in people's satisfaction across all 3 conditions, and no differences between them in terms of how big the effects were or how much the improvements were. And that I should just point out. So this one was for veterans. There were significant improvements for veterans. And there were significant improvements for partners. You'll notice that the office-based effect was a little bit smaller for the partners, although the partners who were in the office-based program also started a little bit higher than they did in the home base, which might have also affected the improvements. So hard to know if there's something going on there or not, or it's just more of a fluky finding, but it looks like it might be a little bit smaller in the office-based version. Okay, so the other thing that we have been working with is the use of psychedelics and other medications to facilitate treatment. And MDMA is one of those medications. It's probably best not thought of as a psychedelic, but it's really what people have described as an empathogen. So it actually seems to work on the neurotransmitters that help people be more empathic toward one another. And so it's kind of a natural match with the couple therapy for PTSD. So we did run a study where we had both members of the couple who got MDMA alongside the couple therapy for PTSD. They had 2 sessions where they came in and got the MDMA that were kind of well timed alongside the protocol of CBCT for PTSD to be synergistic with it. So we did it early on in the treatment when we were teaching people listening skills and sharing skills, and then also right before loved ones talked more specifically about the trauma and processed trauma within the sessions. And the take-home message, now this is a small study. We're currently in the process of running a larger study with a control condition, is that it does significantly improve relationship satisfaction, significantly improves PTSD symptoms, and the effects are quite a bit higher than without the medication. So there is reason to think that perhaps MDMA can catalyze or synergize a couple therapy for PTSD. So it's not just a matter of taking MDMA, but actually thinking about how the medication can facilitate the therapy. And then the other thing that we have been up to is something called Couple Hopes. And just to put a shout out to Larissa and Polly, who have been helping us to spread the word on Couple Hopes, which is a self-directed version of the CBCT for PTSD. It is available online. We have been testing it in various studies. It's mostly all like web stream videos. There are some practice assignments that are interspersed within the modules. There are 7 modules. There's also practice assignments after the modules for the couple to do together. There is an app, as you can see here, that you can download in the different stores in order to facilitate the homework practice. So again, this is part of our effort to actually make these interventions more accessible, because we know there's way more demand for mental health interventions than there are providers who are going to be able to meet those demands. If you're interested in the outcomes, the take-home messages, it does seem to be improving self-reported PTSD symptoms and also improving relationship satisfaction, at least in the partners. Again, not recruiting for people who are distressed. So the fact that there's kind of improvements in general is a good thing. So as we round out today's talk, I just wanted to share a little bit about what I think is the path ahead. That's some like super cool stuff that's happening in taking PTSD and trauma recovery out of the individual and really thinking about the broader context in which people are existing. At the prevention level, a woman named Emily Dworkin, who's at the University of Washington, has developed a program called CARE, which is communication and recovery enhancement. And she is working with recently traumatized individuals. I think her studies are specifically in sexual assault victims, to give them a very brief social support oriented intervention in order to facilitate recovery. Because we know that social support is one of the most robust factors that protects people once they've been exposed. And to be more precise, it's actually probably not that social support protects people, but that if you're in a negative social environment, it's going to put you at risk for going on to have PTSD. In terms of getting people to treatment, so even engaging in treatment, Steve Sayers is doing a program called Coaching into Care. It's a telephone-based program for veterans in the United States, for their family members to get coaching about the kinds of things that they can do and say to increase the likelihood that veterans will get into care. There's also Sarah Campbell is doing a program that's very, it at least includes social engagement in primary care for getting people into PTSD treatment, called BASE. So it includes behavioral activation, which is the idea of getting people more active to improve mood and also to engage more socially in order to improve PTSD symptoms. There are several people at work on thinking beyond couples and adult family members to include children. So Rich Gilman and Kate Chard have taken cognitive behavioral conjoint therapy and mixed it with parent management training to help not just those with PTSD, but also their kids and behavioral problems in their children. There's also an ACT-based parenting group that's being tested. So ACT stands for Acceptance and Commitment Therapy, which is a form of cognitive behavioral therapy that has been tested with those who have PTSD and who are parents to improve parenting. Leslie Moreland and Lauren Sipple are also using intranasal oxytocin to facilitate the couple therapy for PTSD. So this basically, before sessions, each member of the couple takes the oxytocin through the nose. So basically they're snorting oxytocin prior to the session, with the idea that oxytocin is a powerful bonding and attaching agent to help with the therapy delivery. And then there are a couple of my colleagues who are working on more partner-assisted programs. So remember, partner-assisted means having the loved ones be a part of the delivery of individual therapy. So Laura Mice and colleagues are combining partners, including partners in prolonged exposure, at least early on, to give them the rationale and how they can be supportive of that treatment. And also Johanna Thompson Holland and colleagues are working to decrease partner accommodation. So in brief, partner accommodation is this idea that sometimes partners feel forced or maybe want to accommodate the symptoms of the disorder. So not accommodate the person with the disorder, but because of wanting to decrease distress in their loved one, sometimes they will take on more responsibilities or enable. This is another word that people have used, although I'm not crazy about that word, but just to kind of a shorthand for giving you a sense of what partners may do in order to kind of work around the symptoms of PTSD and other conditions that come after trauma. Because those behaviors, while they may be helpful short run, they have these long-term consequences of actually keeping the symptoms in place, if not making them worse, but also deteriorating the relationship. So trying to work on those behaviors alongside individual therapy to improve outcomes and also decrease the burden on partners in having these kinds of behaviors as part of their relationship. So with that, I think I am going to stop because I want to leave just a little bit of time for Q&A. And I'm realizing we got started a little bit late, but just to make sure people feel like they have an opportunity to ask any questions. My information is here. I think that Larissa, in the past, I work really hard to be available to people and including those who have lived experience and want to share their experience with me in whatever way. Please feel free to reach out to me. I would be delighted to hear from you and to offer any resources and support that I might be able to offer.
Thank you, Candace.
Absolutely.
It's always lovely to hear your chats, Larissa and I again. Candace, I would say you're probably one of the front runners when we first heard you, that we knew that this was something we wanted other families to know about, because the research that you do and the modalities that you're bringing together, we know are helpful. And we benefited from listening to your talks. There's no direct questions right now. I do have a quick one though, for you myself, just in regards to most of what you spoke about is stuff in the studies, right? So I know that your conjoint couples therapy, there is therapists out there that do it. So I guess if people are interested in knowing more about how to find a therapist or anything like that, if you could send along some information for us for that, and then we can put it in the presenters booth, because I'm sure there's some people that are interested in that, because it's and maybe you can also just speak quickly to the piece that how it has to sort of go through that research phase before the powers that be, let's say, I'm going to use that as a word, but the insurance companies or whoever's paying for the therapy that see it as an evidence-based therapy for PTSD. Can you speak to that a little bit?
Oh, for sure. No, it's a great question. So maybe the host or panelists can get there's a website that people can go to access information about cognitive behavioral conjoint therapy and providers. So it's coupletherapyforptsd.com if people want to go there. And Couple Hopes is at couplehopes.com. So maybe that's some quick information. And then, so there's kind of a sequence that treatments go through, whether it's an individual therapy or a drug therapy or a couple therapy or an online therapy, that really starts out with like, does this thing even work in a small sample? And then it progresses to a more rigorous test of it. And I think this is part of this, movement to really prove like what we do works, and to reassure the consumer, the clients, that actually people have gone through this and that there is science behind it to show that it works. And so what I would say is that there is a lot of people doing a lot of different things out in the community, and some of it hasn't been shown to work. And so I guess I would really encourage people to do their research as they're out there looking for resources. And it's hard, especially when you're feeling like you have the burden of mental health problems or a loved one who has problems, like trying to sort through what's the wheat and what's the chaff can be hard, but it's a big investment of your time and energy. And for some people, money, if you don't have coverage. So like really trying to, if I had to recommend one resource, and then I'll be quiet, is there are treatment guidelines that are issued for various conditions, including post-traumatic stress disorder, where the Canadian Psychiatric Association or the American Psychological Association have like weighed in and done some of that research for you to tell you like these are things that have been shown to work. So that might be a good resource for people to access in terms of kind of knowing that there's science behind it.
Great. Thank you. Well, welcome back, Huff and Larissa.
Yeah, thank you, Candace, so much. Boy, did you dispel a lot of myths for this person today. One was that it's a one size fits all. Just go to counseling and take care of those PTSD symptoms and everything's going to be fine. Well, that's not necessarily the case. And so I really appreciate that. And very heartened by the fact that the research is still ongoing and there's so many different modalities that we can potentially have access to in different treatment interventions. That's great. So again, on behalf of Atlas and all of us here, thank you so much for spending some time with us today.
Of course. It was my pleasure. Thank you so much for having me.
Wow, that was pretty impactful. The whole day has been really impactful. Just as we have some time, just really want to hear your thoughts. Maybe starting off with you, Polly.
Well, for Candace, there was a few things that stuck out. I know a lot of her information was about research and studies and stuff, but one of the things that really stood out for me was sort of the dose treatments or the retreats, the short-ended things. And, I think in our lives that are so busy and things like that, sort of taking that shorter time period sometimes works better for others. And I know in my previous work with peer support, retreats had definitely a big impact on spouses that went away and for a weekend and had sort of some clinical and peer support pieces to it. So, and like you said, she really hit on that. It isn't a one size fits all, and there's many different treatments. What about you, Larissa?
I guess my reflections were a little more broad. I just so much appreciate that she's giving the opportunity to educate so people can self-advocate. I'm enthused that there's so many treatment options for couples and families together. I kind of used to make a joke when I was providing peer support, when I was chatting with people, to say that, no one educated families about treatment options. No one included them. And I'm not suggesting families should be sitting in therapy sessions, with their loved one, but maybe someone should educate them on what prolonged exposure therapy is and what to expect. Because if the veteran has just attended a session of prolonged exposure therapy, which can be pretty intensive, and then the family member shows up with 3 teenagers in the back of the car ready to go shopping, it's a little bit counterintuitive. So someone has to educate family members. Someone has to educate the member on what might be a fit for them. And so pleased that Dr. Munson and the other presenters today are providing that education so people can self-advocate. And the other thing for me personally is within my journey of supporting my spouse, I found there was a shift for me personally. Initially, my train of thought, it was him and his PTSD. you and your PTSD are preventing barriers. You and your PTSD are providing, barriers to us communicating, for us to do family things together. And once it dawned on me that it wasn't him and his PTSD, it was us as a family tackling his injury, that was the shift for me. And it's something I still need to practice. It doesn't happen. It's not there all the time. It's something I have to be conscious of. But I learned that we were partners or fire team partners in the journey as opposed to being adversaries. And I hope that helped him in his journey and the rest of our family as well. So
Yeah, I think that's really, really important. Again, coming from the veteran perspective, is that entering into this process without feeling like, I'm the person responsible. I was the person that joined the military, went overseas, volunteer. It's a volunteer military, um, and then have this diagnosis, and now I'm bringing it and inflicting it on everybody around me. And it's I think a big takeaway for the whole day for me was that veterans are part of the family, but it's not just an isolated issue, that it involves everybody, right? And that it's really incumbent on me to make that realization, and that families, again, are not an afterthought. You guys have your own needs, your own experiences, uh, and your own struggles with that. But it is definitely a team effort, and we're not alone. We may stand alone sometimes, but we're never alone. And I think the biggest impediment to finding recovery is me. Um, I'm only as alone as I decide to be, and some of the heaviest the heaviest implement is picking up that phone or sending that email. And so yeah, it was a very, very impactful day for me.
Thanks for sharing, Huff. And, I'd just like to thank all the participants that have stayed along with us. Maybe you've come in and out today. Um, I know for me, it's been a little bit heavy at times, and my head feels like it's swimming. And a lot of this information is not new to me. However, every time I say it, it can bring up past experiences, good, bad, and different. Some are great reminders of where I have been, where we have been, and where we are now. And so I'm just truly grateful that Atlas has supported uh, the idea that Larissa came up with, that she pulled me in as per normal, and that we were able to give you our first day of the summit, because we still have another day of great speakers coming up tomorrow, and that Huff was really great to get your insight today from the veteran perspective, because as you said, the veteran is part of the family, and we're a family unit, and we need to work through PTSD, through our wellness journeys together as a family, whatever that looks like.